So this is our big HESI review. We did a light review last week, but this one is going to be more in depth. This one almost identically follows your HESI review book. So we're going to start out with test taking strategies. These are great when you don't know the
Professor,
answer.
I
Yes.
have a question.
Yeah.
So the HSC review you went through last week and this one, we're gonna have to review all of them or just this one?
This one is a lot more in depth and covers everything. The
Mm-hmm.
other one is kind of just the highlights. So they're
Mm-hmm.
both good information. This one is probably better than last week's.
Okay.
Yep.
All right. Thank
Uh,
you.
so when you're trying to guess at an answer, you have absolutely no clue what the answer is. Um, then these tips are going to help you to do process of elimination and figure out what your best guess is going to be. So anytime we see absolute words either in a question or an answer, we want to avoid those. So words like always, never, must, and cure. We know there's no instant cures in medicine. So any answer offering an instant cure is going to be false, not going to be a good answer. And anytime we see those absolutes, it means there's no other option available. So that is the only thing you can do. So we know that that's not congruent with medicine. We know there's lots of different treatment methods that we can use, different interventions that will help a patient. So absolutes are typically going to be a wrong answer. The hardest thing to do is not read into our questions. So no adding vital signs, no making up a backstory for your patient. You have to use just the information that's in the question. One of the hardest things to do. When you're planning your interventions, you want to start with your least invasive first. So if we give you the option of taking vital signs or starting an IV, you're going to want to do your vital signs first, then move to your more invasive IV. Alongside that, we always want to assess before we intervene or treat. So always assess unless your patient is visibly in distress. So if I'm blue and my SATs are 60, I'm not going to do a full respiratory assessment before I intervene and put oxygen on. I'm going to go ahead and put that oxygen on so that I'm not blue and satting 60, so that I'm still alive to be able to complete that assessment. Does that make sense? And then when you're doing your assessment, always start with your patient. Start with your patient before you move on to looking at machines and equipment. Any answer that delays care is going to be wrong. So if you are in the middle of a med pass and you get abnormal lab values, you're not going to wait until you're done with your med pass to call the doctor and get new orders. You're going to call him right away, get your orders, take care of that, then finish your med pass. So don't do anything that would cause you to delay care. When you have opposite answer choices, one of them is likely the answer. So you can narrow it down to those two, and then you've got a 50-50 shot of guessing. So if you have tachycardia and bradycardia as answers, one of those is likely going to be what they're looking for. On the other hand, if you have two similar answers, neither one of them are going to be right, because we're not going to ask you to split hairs like that. We're not going to give you bradycardia and low heart rate as two potential answers and have you guess which one we were thinking. They both mean the same thing. So neither one of them are going to be your right answer. When you're reading your answers, the whole thing has to be correct in order to be a right answer. So if you have a list of 4 interventions and you know you would only do 3 of them, that entire answer is wrong because of that one intervention that you wouldn't do. So you have to take the whole thing as a whole. You can't pick and choose what you like out of the answer. And then lastly, therapeutic communication questions are some of the easiest on the HESI or on the boards because the answer is going to be written in the question. So the whole point of therapeutic communication is asking open-ended questions and then restating what the patient is telling you. So it's almost going to be word for word what the patient says in the question is going to be repeated again in the answer. So you can kind of just match them that way. And that's a really easy way to get your therapeutic communication questions correct. So the big overarching principle of the HESI and your boards is it's a safety test. So making sure that you can practice safely. So as long as you are picking the safest intervention and the safest option, then you're going to be in good shape. So just frame it in what is going to keep my patient safe, and then you'll be able to do well. Does anybody have questions on those test taking strategies?
Yeah, I have a question.
Yeah.
Can you please give an example about if one part of the answer option is wrong,
Yep.
all is wrong. So can
Yep.
you give an example about it?
So if we said for a patient interaction, we are going to do meticulous skincare. We're going to keep the feet positioned at the foot of the bed, and we're going to keep the head flat. If that was one option in the answer, so if that was answer A for us, then we know that we are going to do meticulous skincare and we're going to typically keep our head flat, but we don't want our feet to be positioned at the foot of the bed because we need them to have that room for the weights to pull. So that would eliminate that entire answer. Even though there's two good interventions in there, because we said keep their feet at the foot of the bed, that eliminates that entire answer. Does that make sense?
Yes.
Okay. So
Thank you.
sometimes they'll mix good interventions with bad interventions, or they'll give you a list of symptoms and like two of the three are going to be right.
Okay.
So those are the things you have to watch out for. That's why you have to read the entire question and read the entire answer. And then I tell students to go back and reread the question with their answer to make sure that they didn't miss something.
Okay.
And you guys have plenty of time to do all that.
Okay. All right. Thank you.
Yeah. Okay, so starting off, developmental milestones. Those milestones for the first year are super important because that kind of starts the whole process of growth and development and making sure that we're on the right track. So be very familiar with your first year milestones. Afterwards, we kind of trail off. We aren't as focused on those milestones. So for that first year, our birth weight doubles by the time we're 6 months, triples by a year. We start social smiling at about 2 months. We can roll over at 5 to 6 months, start playing peekaboo after 6 months. We're transferring objects between our hands at 7 months. And that's also when we start to see stranger anxiety start to creep in. We should be able to sit unsupported at 8 months, be taking our first steps between 10 and 12. Just remember by the first year, you should be able to take your first steps. Simple words by that first year as well. And remember that our infants are exploring through motor and oral means. So everything goes in their mouth and they're learning how to move their body around in their environment. Remember when we talked about separation anxiety, there were 3 different stages. Protest is that initial outburst when mom and dad first leave. Then we move into despair, where we're sad, we're withdrawn, we don't want to play with anybody. Then we move into denial or detachment, which is where we go back to normal functioning, we're playing with toys. And when mom and dad come back, we are likely going to ignore them as a means of dealing with the pain of them leaving. What else is in here? Should be able to use scissors by the time we're 4, tie our shoes when we start getting into school, so 5 years old. And then we get that growth spurt as we hit adolescence. Our temper tantrums are normal in our toddlers. So it's just part of them exercising autonomy and trying to gain that independence. So normal behavior. And then again, we'll see kind of that rebellion in adolescence when they're trying to establish their own identity.
I have a question really quickly.
Yep.
It was it's kind of it's not like really a question on there, but like let's say like a child was, on the pacifier.
Mhm.
Typically, when do you start to try to take it away?
Um, Usually when their teeth start coming in. So as their teeth are coming in, then you want to start kind of weaning off of that pacifier, so that we make sure that we have good oral alignment. Um,
But I feel like everybody's different because I've
Yeah,
seen kids that are 3
everybody's
years
gonna
old
be-
that still have it.
Yep, everybody's going to be super different, and it kind of all is when you start the process, and how consistent you are with the process.
Yeah, that's what I'm dealing with now. My son is 18 months and he's on the pacifier bed, like,
Mm-hmm.
and like he doesn't have it throughout the day, but only like when he goes to sleep. So I already start trying. But
Mm-hmm.
like if he wakes up in the middle of the night, he'll start crying for the pacifier, and it's like I don't want that, and I don't know when I should take it away. I went to the doctors yesterday. They said I need to take it away. I don't know what to do.
Yeah.
Just like my dad did. My dad threw it out the window and told my brother that Birdie got it.
Yeah, there's lots of different approaches that you can use. You just have to figure out what works for your child and your family.
Okay, thank you.
Yeah. For our school age kids, they are in Erickson's stage of industry. So that is where they are finding activities that they can do that give them a sense of pride and accomplishment. So it's all about those good feelings from an activity that they do. And this is where peers start to influence their decision making. So they want to be able to do things correctly, and they want to be praised for doing things correctly. The more recognition they receive, the harder they're going to work. But if we're constantly telling them that they're doing things wrong or not to do it that way, it's going to make them lose motivation. So remember, our infants are able to feel pain starting at 6 months, or they're able to remember pain. They can feel pain the entire time, but they're able to remember it at 6 months. And then our toddlers and preschoolers are really afraid of invasive procedures and body mutilation. So even if we tell them that we're just doing a simple procedure, in their mind, we're chopping off their entire extremity. So they just think worst case scenario about everything. Our school age kids are focused on control. So they're starting to have that independence, and they're really proud of the things that they can do for themselves. So then we throw them in the hospital and we don't let them do anything for themselves. We don't let them make any decisions. And that's what makes them the most afraid, is that loss of control. So by giving them opportunities to make choices, even if it's as simple as what color Band-Aid do you want, that really helps to reinforce that control, give them a sense that they can still make those choices. And then with our adolescents, remember, their major concern is their body image. So if we can have things from home, like their own clothes or their own blankets, we can help with reinforcing that sense of identity. We talked about accidents being the major cause of death in children. Remember, for adolescents, it's specifically motor vehicle accidents that are the leading cause of death. So we need to make sure that we are educating parents on how to prevent accidents and keep their children safe. When we're looking at pain scales, we have to make sure that it's appropriate for the child's age and developmental level. So we can use the CRIES scales for our infants that are nonverbal, and that looks at crying, whether or not they require oxygen, increases in their vital signs, their expression, and sleepiness. PRS is just a pain rating scale, and it's the overarching umbrella term for multiple different scales. So one of those is the faces scale, which we're all familiar with, where we get the cartoon faces 0 to 10, and you pick out which one correlates with the number of your pain. We also have the poker chip scale, where you give the child 4 poker chips and they give you back whatever correlates with their pain. So if they give you one back, they're only in a little bit of pain. If they give you all 4 back, then they're in the worst pain of their life. We can use our number scale for anybody over 9. And then our Oucher pain scale is just like our FACES scale, but it uses culturally specific photographs instead of those cartoons. So we know that some cultures don't express pain in the same way. They might have a more flat affect, or they might be more expressive. So this pain scale makes sure that it takes into account those differences. And then make sure that when we're documenting pain, we are believing the child. So whatever the child says their pain is what it is. Whenever they say they're in pain, they are in pain. And then for our nonverbal kids, we're going to use that observational assessment, like a FLAC scale or the CRI scale, to be able to assess where they're at. We always want to start with our non-pharmacological interventions first, based on the child's age and development. Infants are going to want pacifiers, being swaddled, holding or rocking. Our toddlers and preschoolers are going to respond better to distraction, so blowing bubbles, music, TV shows, their favorite toy. When we have to move on to pharmacologic interventions, make sure that we're double checking that the dose of medication is safe for the child. We want to make sure that if we're giving an opioid, that we continue to monitor the child's vitals afterwards. Remember, opioids are respiratory depressants, so we want to keep a very close eye on their vitals afterwards. And then we can do a PCA pump. So the button that you push to give your own pain meds as young as 5. And then remember that kids might deny pain if they think they're going to receive an injection. So we either want to do oral medication or IV medication instead of doing injections. Moving on to communicable diseases. So rubeola is our measles, and it causes photophobia or light sensitivity. And then we end up with Koplik spots in our mouth. And these are tiny white spots that are inside the mouth 2 to 3 days after the start of symptoms. And the confluent rash is a red splotchy rash. And those splotches kind of all run together. We can vaccinate against measles with the MMR vaccine, and they get 2 doses, one at 12 to 15 months and one at 4 to 6 years. For chickenpox, remember we have that long incubation period, and it is that viral disease characterized by those spots that we see. Those lesions begin on the trunk and then they spread outward. It's extremely contagious. And we are contagious from 2 days before we start to see that rash all the way until all of those spots have completely crusted over. So once everything is fully crusted, then we're no longer contagious. And again, we have a varicella vaccine that can be given in 2 doses, one at the 1st year and the second at 4 to 6 years. For German measles, or rubella, the important thing to remember is that it causes a serious risk to pregnant women. So it can be passed to the unborn child and cause either miscarriage, heart problems, can cause loss of hearing and eyesight, intellectual disabilities, and liver and spleen damage. So if a younger or an older sibling is around and contracts rubella and is around a pregnant mom, it can be passed to the younger sibling and cause a lot of birth defects. So we have to make sure that in the event that we have rubella, that we isolate the child while they're contagious. We want to make sure that we're treating with any fevers with a non-aspirin product so that we're not causing Rye syndrome. This is one of those disorders that has to be communicated to the health department for tracking. And then making sure that we're preventing itching and giving Benadryl to help with that itching and washing our hands really well. For nutrition, remember iron deficiency is really common in our pediatric population as they are weaning off of their formula and relying on solid foods for their iron source. And then it happens again in adolescence as they have that really rapid growth spurt. Our preschoolers and school age kids are also commonly deficient in vitamin A, C, B6, and B12. When our adolescents hit that big growth spurt, they need more calories, proteins, zinc, calcium, and iron to help with that bone support and growth. When we're trying to evaluate a patient's dietary history, we can do a couple different things. The 24-hour recall is just everything they had to eat and drink in the last 24 hours. We can ask them to keep a food diary where they keep 2 weekdays and 1 weekend day of everything that they eat. That way we can see the differences between how they eat during the week when mom and dad are busy with school and work and all the activities versus the weekend when they have a little bit more time. And then a food frequency record is just a basic questionnaire that asks family how often a child consumes a certain food group. So how many times a day, a week, a month do they eat particular foods? And it's all for the food groups. When we're looking at diarrhea, we're really concerned about dehydration, metabolic acidosis, and if it goes prolonged and untreated, it can lead to shock and death. Remember, our signs of shock are decreased blood pressure, increased pulse. We can have that mottled to gray skin color where they kind of look real pale and they have all the veiny lines through them, look like marbled cheese. That's mottled. And then changes in their mental status. When we're looking for dehydration, we're assessing their skin turgor. How fast does their skin recall? They might have an absence of tears, dry mucous membranes. They're going to be losing weight. In infants, we can see sunken fontanelles, decreased output. Remember, when we're treating dehydration, before we give IV potassium, we have to make sure that the child has appropriate urine output. So we're looking at 1 to 2 milliliters per kilo per hour because potassium is cleared through our urine. So if we don't have enough urine output, then we're not going to be able to clear that potassium. So when we have diarrhea, we're going to monitor our hydration status, our vital signs, do frequent I's and O's. We don't want to do anything that would cause skin breakdown or discomfort for the child, so no rectal temps. And then we're going to give IV fluids to help restore that fluid and electrolyte balance. Going to be doing lots of labs to figure out what the cause is, check for any complications that might be happening. And then they will be on isolation precautions until we find out the source of their diarrhea. When we're assessing for child abuse, we want to be looking for injuries that don't match the child's development or skills, as well as injuries that don't match the story that the caregivers are telling us. Anything that would cause a delay in seeking medical care. So if you have a severely injured child and it takes parents 6 hours to bring them in, that's a delay in seeking medical care and could be a sign that we're not providing appropriate care for this child. When we have bruises in odd places or in various stages of healing. So remember when we talked about bruises, they have different colors depending on how far we are from the injury. So if we see black and blue bruises, green bruises, and then really pale red bruises on a child, we know that we have 3 different times that we've been injured because they're all in various stages of healing. So if parents tell us, oh, they just bumped into the wall, and you have all those different versions of bruises, we know that story doesn't match. Same thing with the unusual places. They're typically somewhere that's covered by clothing so that they're not visible. Same thing with burns. We can have specific shapes with our burns. You can tell, did they use an iron? Is it a perfect circle where it might have been a cigarette? And then we have to watch for immersion burns. And this is just really uncomfortable, but symmetric in shape where you can see exactly how far the child was submerged in the water. So you're going to see like typically their lower half is going to be burned, but their upper half will be fine. And there'll be just this symmetric ring where they were being held and brought back up. Whiplash injuries can be caused by shaken baby syndrome. Bald patches where hair was pulled out, same thing with fractures and bruises. If we've got various stages of healing, then we have multiple insults of injury. Failure to thrive can be a sign of neglect. And then torn, stained, or bloody underclothes can be a sign of sexual assault. So no matter what, we are mandated reporters for all cases of child abuse. So follow your state's policy on how to do that. We know our kids are at high risk for poisoning because they love putting things in their mouth. So any toxic level of a substance, either by being ingested, inhaled, or being absorbed through the skin. Remember, no longer using syrup of ipecac because we don't want to induce vomiting. So if we induce vomiting, we can cause more damage on the way up because syrup of ipecac doesn't neutralize that toxin. For signs and symptoms of respiratory distress, we're looking for restlessness, increased respiratory impulse, sweating, flaring nostrils, retractions. We can hear them grunting, trying to keep their alveoli open. Adventitious breath sound, so any abnormal breath sound that we hear or the lack thereof. Using those accessory muscles. So we'll see them using their abdominal muscles. We might see them head bobbing, doing anything that they can to get more air in. And then changes in our labs, cyanosis and pallor. So if we're pale or blue, those are all signs of respiratory distress. So we're going to monitor our respiratory status carefully. We can do bronchodilators and steroids if we have acute respiratory distress. These patients are going to need oral hydration and possibly IV fluids depending on how much difficulty they're having. If you can't breathe, you're not going to hold your breath long enough to take a drink of something. So we might need IV fluids. Keeping a close eye on our labs and giving therapies as prescribed. For the HESI, remember above 95 is normal for our oxygen saturations. I know in class we said 90. And then we can give breathing treatments and corticosteroids to help with resolving that respiratory distress. Looking specifically at cystic fibrosis. Remember,
I have a question.
Yeah.
So 95, so for any kind of like question would be like, which is an abnormal or some kind of, I can't even talk anymore, vital sign that we need to treat or something?
Yeah.
We should be looking for 95 and above for HESI or is that, I'm just confused.
Yes, for HESI. Yep.
Okay, thank you.
Okay, so cystic fibrosis is our multi-system disease. Remember, those thick secretions cause issues with pretty much every body system. So we've got really thick secretions that block our airways. It also keeps our pancreatic enzymes from getting into our GI tract. We lose sodium and chloride in our sweat. So that's why we do that sweat chloride test as a diagnostic procedure for this. Can cause biliary obstructions and then also issues with reproductive system. So our kids with cystic fibrosis need 150% of normal caloric intake in order to maintain just their everyday growth and development. So they need a lot of extra calories just to survive. So these kids, we're gonna try and prevent respiratory infections at all costs. They're going to need their pancreatic enzymes with their meals to help them absorb their nutrition that they need. For infants, we can use applesauce, rice, cereal. Same thing with older kids. Those enzyme capsules are going to be too big to go through a bottle nipple. So we're going to have to give them something else to be able to take that with. Remember, with cystic fibrosis, they have a hard time with processing fat. So we need to make sure that any vitamins that we give them are in a water soluble form. So we normally give vitamin A, D, E, and K to infants. So we need to make sure that those are water soluble. We're going to do our breathing treatments and help them with clearing their airway. So we're going to do a lot of postural drainage and percussion to help them loosen up those secretions so that they can cough them out on their own. And then their diet's going to be high calorie, high protein. The fat is, they need fat for the growth and development, but remember, they're going to need a lot more calories because they're not digesting it well. So the more we give them, the better chance we're getting some of it into their body. And then moderate to low carbs. Anytime we're administering oxygen, there's different methods that we can use. We can use an oxygen hood for infants that's going to be very similar to our mist tents, where we just put this big box over top of their head and we've got free-flowing oxygen just going around them. With the mist tents, we also have humidity in there. We can use nasal prongs for low to moderate oxygen concentrations. With our pediatric population, we want to make sure that we keep those like 2 liters and less with our infants. When we're, know your normal blood gases. Those are going to be important. We already talked about pulse oxes. Okay, I think that's later on. For epiglottitis, remember that's the swelling above our vocal cords and can cause us to lose our airway. So we have to make sure that we have a tracheostomy set at the bedside before we examine the child's throat. So don't put anything in their mouth or do any invasive procedure that could make them upset before we have that alternate airway, because we can cause a laryngospasm and then we won't have an airway. Bronchiolitis is going to be inflammation of our small airways, typically caused by the RSV virus. Really easy to spread in the hospital and close contact with infected people. So these kids, again, are going to be in isolation. We need meticulous hand washing to make sure that we're not spreading. We're going to keep a close eye on their respiratory status. They might need suctioning to help clear secretions. Again, IV support depending on how severe their disease is. And then we can give the Synergist vaccine to help provide that passive immunity against RSV. So that's going to be more so for our high-risk kids, like our NICU babies, or a kid with a congenital heart defect. For any respiratory disorder, your #1 priority is going to be maintaining a patent airway. So any nursing action that is revolving around airway patency is probably going to be your right answer. And respiratory disorders are the primary reason that pediatric patients come into the hospital. So it is something that is frequently tested on both HESI and NCLEX. So make sure you know your normal respiratory rates and those signs of respiratory distress. So moving on to our ears and our sinuses and all those other things attached to our respiratory system. Otitis media is inflammation of our middle ear, so that middle ear infection. They're going to be on antibiotics. We want to bring their temperatures down slowly using tepid baths. We don't want to bring it down too quickly. Remember, anytime we have a high fever with a pediatric patient, we're at risk for febrile seizures. We can use Tylenol to help with that fever as well. If we position them on their affected side, so whichever ear is infected, it will help to alleviate some of that pressure and the pain associated with it. We can also use warm compresses. For tonsillitis, we've got different causes. We really want to be watching for signs of acute pulmonary nephritis and rheumatic heart disease. Those are complications of an untreated infection, especially when we see strep. If we're going to have our tonsils out, we need to make sure that we're assessing our clotting factors before we go to surgery. So doing a prothrombin time and a partial thromboplastin time to make sure that we don't have any risk for bleeding after surgery. Warm saline gargles, ice chips can be helpful for pain. We'll be on antibiotics after surgery, and then if we have a fever, we can give Tylenol. When we're looking for signs of post-op bleeding, we're watching for that frequent swallowing. If they're vomiting fresh blood or they're constantly clearing their throat, that could be a sign that they've got something tickling in there. So blood dripping that's causing that tickle that makes them clear their throat. Questions about respiratory? Okay. Move on to cardiac disorders. So remember, we have our acyanotic heart disorders where we've got enough oxygen circulating through our body so we stay nice and pink. Or we have cyanotic heart disorders where we don't have enough oxygen floating through our body and we turn blue. In our kids with those cyanotic heart disorders, it's really common for them to have polycythemia. So their body overproduces red blood cells in hopes of getting more oxygen to be carried through the body. So remember, our hemoglobin is what carries our oxygen through our body. We can diagnose congenital heart disorders through electrocardiograms, which look at your actual heart rhythm, or we can do an echocardiogram to look at your anatomy and blood flow. Common signs and symptoms across the board. We can have an irregular heart rate, rhythm. We can hear those murmurs, irregular pulses. We can see cyanosis and clubbing of the digits where like their fingertips get real swollen and blue. And that's usually a late sign from prolonged cyanosis. They also have difficulty eating and gaining weight because they're using so much energy to stay alive, frequently spit up. Respiratory infections, especially if they have increased pulmonary blood flow. They're going to wear out very, very easily. And also many congenital heart defects can be caused by maternal infection while she's pregnant. So know your normal cardiac rates. And remember that if a child is crying or has a fever, it will increase their heart rate. So you might see an elevated heart rate because the child's crying or has a fever, not because there's an actual defect. When we're trying to support nutrition for these kids, we want to give them small, frequent feedings with high calorie formula or breast milk so that we're not wearing them out eating and not burning off more calories than they're actually taking in. A lot of times these kids need tube feeding to meet those nutritional needs. For heart failure, that's when we've got too much volume going into the heart and the heart can't pump it out to the body. It's commonly associated with those disorders that keep you pink, so those acyanotic defects. We want to watch for tachypnea, shortness of breath, tachycardia, feeding difficulties, abnormal lung sounds, swelling, sweating, weight gain is very, very common. We're going to want to keep the head of the bed elevated in these patients so that we can use gravity to keep that swelling away from their airway, giving them oxygen, diuretics to help with the swelling. We can also give digoxin to support their cardiac output, being able to pump out more. They're going to be on daily weights and strict I&O, and they're going to be on a low sodium diet to make sure that we're not causing additional swelling. Anytime we're doing daily weights, it's important that we use the same scale every time so that we know that we're getting that accurate comparison. Rheumatic fever is one of those reactions to a strep infection. If it goes untreated, it can cause damage to your aortic and mitral valves. So these kids, after they have a strep infection, are going to be on 5 years of penicillin to make sure that they don't end up with a recurrent strep infection, and to make sure that we fully treat that and eradicate the strep infection. We also give aspirin for its anti-inflammatory and anticoagulant actions. We don't want to cause blood clots. For Kawasaki's disease, that's where they've had a high fever for several days. They've been on antibiotics and they're still not getting any better. So they come in with bright red eyes, strawberry tongue, swollen hands and feet, cracked lips, rashes along their body, extremely irritable. And this is one that we don't have a test for. We're just basing it on those signs and symptoms that we see. So these kids need IV immunoglobulin. We're going to give them Tylenol for their fevers. We can help with the skin discomfort with using lotions, cool compresses, good mouth care. And then we're going to keep a close eye on their vitals and eyes, nose. That's it for cardiac. We good there? Okay. Neuromuscular. So Down syndrome is our trisomy 21. Commonly associated with heart defects, frequent respiratory infections. They have a difficult time feeding and delayed development because they typically have very poor tone. They tend to be floppy babies. And then they also can have skeletal defects. So our goal is helping them reach their optimal level of functioning, whatever it is for that particular child. With cerebral palsy, we are at risk if we're low birth weight, extremely premature, or it can be a result of a maternal infection. Causes cognitive impairment, can cause seizures and failure to thrive. So when we're feeding a child with cerebral palsy, we want to make sure that we are doing everything we can to prevent aspiration. So they have progressive weakening that makes it difficult for them to protect their airway when they're eating. So we need to make sure that they're upright, and they may need some jaw support while they're eating, especially with our infants. With spina bifida, we can also have hydrocephalus or a myelomeningocele, can cause neurologic impairment. Remember when we talked about spinal disorders, anything below that defect is going to have poor communication with the nerves. So we can be at risk for a neurogenic bladder and poor anal sphincter tone because we just don't have that good communication. We don't know when we're full. We don't know when we need to void because our nerves aren't getting where they need to go. Can also cause congenital dislocated hips, clubbed feet, and then skin problems. Remember, these kids are at risk for latex allergies. So we automatically do latex precautions so that we don't put them at risk for anything. And then spina bifida can be prevented by mom taking folic acid before she gets pregnant and continuing to take it throughout her pregnancy. Hydrocephalus is an obstruction in our cerebral spinal fluid going between the ventricles, which makes them enlarge and causes pressure on our brain. So spina bifida, meningitis, both put us at risk for hydrocephalus. Make sure you know the signs of increased intracranial pressure. They're going to be opposite of shock. So with shock, we have an increased pulse and decreased blood pressure. With increased intracranial pressure, it's the other way around. So we have a decreased pulse, increased blood pressure. When we're trying to determine whether or not the child has increased intracranial pressure, one of the things that we notice is a change in behavior. So we need to know from parents what the child's usual behavior is, what they're usually able to do, what their skill level is, so that we can assess for those abnormals or those changes. These patients are going to be on seizure precautions. Anytime we put pressure on the brain, we're at risk for causing a seizure. We're also going to keep that head of the bed up so that we can use gravity to help drain some of that pressure, extra fluid. And then we're going to prepare for surgery. So these kids have a VP shunt that's going to be placed in the ventricle to drain that extra fluid, and it goes all the way down into their peritoneum to drain that extra fluid. Whenever they have a shunt, we want to make sure that we don't pump it. The shunts are extremely delicate, and anytime that you pump that shunt, you are changing the pressures in the ventricles in their brain. So make sure that you are following your orders very specifically. Remember the different types of seizures that we talked about? We've got the traditional tonic-clonic or convulsive seizures where we're actually losing consciousness. We have an absent seizure where we have a momentary loss of consciousness. You might only notice it because all of a sudden they kind of stare off into space. You lose their attention, but they may or may not lose consciousness with those. And then we've got myoclonic where we've got those contractures and then the muscles relax, but they don't lose consciousness. And then atonic where they just drop suddenly. Medication noncompliance is going to be the most common cause of an increase in seizure activity. Remember not to put anything in their mouth. For meningitis, remember that is brain and spinal cord. Encephalitis is brain only. And usually caused by a bacteria that enters through either our ears or our nasopharynx. Really easy, really close proximity to our brain. So opportunity is there. These patients are going to be on antibiotics. They need to be isolated for 24 hours after we start antibiotics. They're going to need frequent neuroassessments to watch for complications or deterioration. They need a quiet, dark environment to give their brain opportunity to rest. And again, seizure precautions. We want to make sure that they stay nice and comfortable so that those pain signals aren't triggering. So they might be easier to have their head elevated, maybe on their side. Our infants are gonna have daily head circumferences to watch for any increase and swelling. And then we can use the Hib vaccine to prevent that H influenza infection that frequently causes meningitis. Rye syndrome is where we're giving aspirin with flu-like symptoms and can cause this whole cascade of events that happens. But some of those causes are when we're giving aspirin when we've got flu or in response to chickenpox. So anytime we have flu-like symptoms, no aspirin. It's best to avoid aspirin in general in pediatrics. One of the most common signs of a brain tumor is a headache first thing in the morning. Patients will usually come in when they've had a headache, vomiting, they may not be able to concentrate or have personality changes. In infants, we can see their sutures widening, their fontanelle will be really taut and tense. We might see changes in their walking or their ability to do previously acquired skills. We have to be very careful with how we position our patients after surgery. Sometimes if we have a large incision, we're not going to be able to lay on that side. We may have to lay flat depending on how intense the change in our intracranial pressure is. Making sure that we keep a close eye on our I's and O's because overhydration can increase our intracranial pressure. So definitely something we don't want. Muscular dystrophy is most common in our boys between 2 and 6 years old. It's that progressive weakness that we see. So we see that waddling gait. They can be really clumsy. They have a difficult time standing up. We can see hypertrophied calf muscles and then cognitive developments. See that big sway in their back. And eventually they will be wheelchair dependent or confined to bed. Questions there? Okay. Renal disorders. Acute glomerular nephritis is that reaction to our strep infection. We see elevations in our labs. We can see mild to moderate edema. This is that periorbital edema around their eyes. They can be irritable and lethargic. This is the one that causes hypertension. We also see blood and protein in our urine. So these kids, frequent I's and O's, lots of blood pressure checks to make sure that we don't have hypertension, daily weights again, low sodium, low potassium diet to make sure that we're able to clear effectively and not cause extra edema. Usually they're going to be on bed rest when they first come in, and obviously give hypertensives or antihypertensives if our blood pressure is high, watching for seizures, congestive heart failure, and renal failure. When we're assessing for renal failure, the first thing that happens is we have decreased output. We can also see a high specific gravity, meaning that the kidneys can't concentrate the urine anymore. The other one is nephrotic syndrome, and this presents with that generalized edema. So everything is edematous, and it starts off mild and progresses to severe edema. We are lethargic, have difficulty eating. We have that frothy urine, and we're dumping tons of protein into it. And we have decreased serum proteins and elevated serum lipids. So infection prevention is going to be really important, and maintaining bed rest while we're all puffy and swollen. We can give steroids to help with moving some of that fluid, and small frequent feedings of normal protein, low salt diet. These kids are also going to be daily weights. UTIs, I feel like we're all pretty familiar with. Infants are going to present with very vague symptoms. You might just see behavior changes, not eating well, strong smelling urine. Our older children are going to present with those more traditional signs. Education is the most important thing with UTIs, making sure that we're collecting appropriate specimens so we're not getting contaminants that might skew our results. And then lots of teaching for our parents, making sure they take all of their antibiotics, when to come back for follow-up specimens to make sure we don't have a recurrence that's just not showing with symptoms. Avoiding bubble baths, wiping front to back. We can also increase our acidic fluids, so apple juice, cranberry juice. That makes it less comfortable for the bacteria to live, so they tend to go away. Our Wilms tumor, that's that encapsulated tumor that's attached to our kidney that parents or the physician, pediatrician typically find just on a normal abdominal exam, can cause elevated blood pressures. The important thing is that we don't palpate the abdomen. We want that capsule to stay intact until we do surgery, so that we're not getting these free floating cancer cells throughout the entire abdominal cavity. So no abdominal palpation with the Wilms tumor. For hypospadias and epispadias, we have the urinary meatus in an inappropriate location, can cause altered voiding streams. We want to do surgery before preschool so that we don't have any issues with toilet training. Also, before we're getting into our adolescence where we're working on our sexual identity. For renal failure, we want to be watching for, or it's caused by dehydration, any trauma, or an obstruction, typically caused by either a congenital anomaly or an infection. And that is it for renal, my friends. Move on to GI now. So with our cleft lip and palate, that's where we have the disconnect either in the lip or the top of their mouth. Obviously causes feeding difficulties, increases for ear infections because we have that great passageway into our sinuses, can cause hearing loss, dental problems, difficulty with speech. Parents often feel a sense of guilt and disappointment associated with their child having a pretty obvious malformation, So a lot of times it helps them to see the before and after pictures from surgery to see how minimal the scarring is and the fact that they can have a normal childhood after surgery. With esophageal atresia and tracheoesophageal fistula. So remember, our esophagus ends in a blind pouch, doesn't go anywhere. And we end up with that connection below to the trachea. So we're at high risk for aspiration. These kids have to have surgery to correct it. They are unable to swallow their secretions. So it ends in that blind pouch. So we typically have continuous suction in there to get rid of their secretions for them. They need their head of bed elevated so that they're not at risk for aspiration. And they will be NPO until they have surgery. So they have to have that pacifier to help with their development. Pyloric stenosis is our projectile vomiting across the room. These infants are always hungry, really irritable, have weight loss, and at risk for dehydration. That's that olive-shaped mass in our right upper quadrant. And we can see visible peristalsis. So you can actually see the food moving through their intestines if you look at their stomach. Post-operatively, we're going to have small oral feedings. We're going to start with electrolytes or that glucose water Pedialyte, and then move back to breast milk or formula. They should be on their right side in semi-Fowlers after eating to prevent aspiration if they would vomit again. Frequent burping to alleviate some of that stomach distension. And then close eye on their weights and I's and O's as we help them catch up their growth. Intussusception is where one part of the intestine slips into the other part. This is the one that causes those current jelly stools. A lot of times we'll see this all of a sudden acute pain in the abdomen. And it's the sausage-shaped mass where you've got that doubling up of the intestine. These kids need fluid and electrolyte balance. And this is one of the ones that can correct itself. So hopefully we can just help that move back out where it belongs and not have to do surgery. But they will need extra calories to help replenish what they lost. For Hirschsprung's disease, that's where our nerves are not transmitting all the way through the bowel. So we have a portion where the nerves aren't firing. We take that portion out, and we might have to do a temporary colostomy when we do that. So we'll take that bad portion out, let the bowel rest, let them grow a little bit so we can make a good reconnection, and then we'll reverse that colostomy. We don't want to put anything in their rectum because they don't have nerve endings down there. So we are at high risk for perforating their intestine if we put anything in there. Appendicitis is the exact same in pediatrics as it is in adults. Remember, we want to make sure that we intervene before it ruptures or causes an abscess. We've got that pain at McBurney's point, and a sign of perforation is that temporary relief of pain after the rupture. So they'll have pain, that appendix will rupture, all of a sudden they'll feel relief, and then typically the pain will come back afterwards. With celiac disease, that's our inability to tolerate gluten. So no wheat, rye, barley, or oats in our diet. We have bulky, foul-smelling stool. We excrete a lot of fat into our stool. Can cause abdominal distension, anorexia, difficulty with growth. They have to have lots of education on that gluten-free diet, and they will be followed very, very carefully to monitor how they're growing. Gastroenteritis is going to be inflammation of our stomach and intestines. We need to correct that fluid and electrolyte imbalance. Also watch for neurologic assessment changes as a result of the changes in our electrolyte status. Proper hand washing so we're not passing it around among the unit. And remember, when we're rehydrating, we want to avoid fruit juices, soda, and sugary drinks we're really looking at fluids that can help restore that balance of what we're missing. And then we don't want to give anti-diarrhea meds and mask symptoms. Okay, kind of moving, well, blood disorders are next. The first one is iron deficiency anemia, which we already talked about. We have inadequate stores when we're developing as a fetus. We get some passed from mom, but we deplete those very, very quickly. We also have deficient intake. We can have chronic blood loss, or our body just doesn't use the iron well. So if it goes on for a long time, we can have cardiac issues because our heart muscle just gets so weak, and failure to thrive. So here's your normal hemoglobin values. Those are important to know. These patients fatigue very easily, so they need rest periods. We're going to supplement with oral iron in between meals with vitamin C so that we increase our absorption. We're going to limit our milk intake because that decreases our absorption, and then encourage those dietary sources as supplementation. For hemophilia, that's where our blood doesn't clot correctly. We need to watch for signs of bleeding into the joints. Anytime we have a minor bleed, we're going to do our RICE interventions, rest, ice, compression, elevation. We can give factor replacement for whichever clotting factor they're lacking. Need to be using soft toothbrushes, making sure we're doing fall prevention, so we're not causing those soft tissue injuries, and they need a medical alert bracelet. Sickle cell disease, that's those C-shaped cells that link onto each other and then cause obstructions in our vessels. They also have a non-functional spleen, so they're at risk for frequent infections. They can have chronic anemia. And then we have those vaso-occlusive crises, or those sickle cell crises, which vaso-occlusive are the most common. The more hydrated we can keep our patients, the more diluted those C-shaped cells are, so it makes it harder for them to latch onto each other. We can also give folic acid to help stimulate red blood cell production. The more red blood cells we make, the better chance we have of producing some normal ones to help, again, dilute those crescent-shaped ones. Looking at leukemias, ALL is our most common, usually accounts for 80% of childhood leukemia, and that's where we're making those immature white blood cells instead of normal white blood cells. So immature, they don't work well, and we're going to use 4 phases of treatment. So we're going to do that really aggressive treatment initially to get rid of all those immature cells. Then we're going to be on maintenance therapy to keep us going. In the event that we have a relapse, then we can do that reinitiation where we get another round of intense therapy. And then if we have any tumors outside of our blood system, then we can treat those as well. Moving on to metabolic disorders. So hypothyroidism, where we don't have enough thyroid hormone, causes cognitive impairment and growth failure. We're looking at T3, T4, and our TSH. And we test that on that newborn metabolic screen. So that heel prick that we do at 24 hours of life. And these patients often present as the good, quiet babies. So they wake up, they eat, they go right back to sleep because they are having that fatigue associated with it. So they tend to be very hypoactive. We can see delayed meconium passage, all these things that slow us down. Remember, when we don't have enough thyroid hormone, we slow down. They can have a large protruding tongue. We can see changes to their skin and their hair. They tend to be really lethargic and sleepy. So we're going to do that newborn screen to rule out hypothyroidism after they're 24 hours old. We're also going to help with thyroid replacement if we need it, and teaching parents the signs for too much and too little medication. They're going to be in constantly for lab draws to make sure that our thyroid levels are appropriate But like I said, too much medication speeds us up. So increased heart rate, irritability, fever, weight loss, diarrhea. Too little is going to slow us down. So we'll be lethargic, fatigued, constipated, poor feeding. PKU is another disorder that's tested on our newborn screen, and that's where our body can't use amino acids correctly, specifically phenylalanine. So it can cause central nervous system damage and causes a decrease in melanin. So the children tend to be light skinned with blonde hair because we don't have the melanin that makes the darker pigments. We need to make sure that we know those normal milestones so that we can assess for developmental delays that could be associated with PKU. They have to be on a low phenylalanine diet because obviously they can't metabolize it. So they're going to be on these super special formulas at least until they are 2. They also have to avoid certain foods that are high in phenylalanine, like high protein things like meat, milk, dairy products, eggs. So they're going to be really reliant on fruits, veggies, juice, cereal, bread, starches. Also have to make sure that they avoid aspartame, so NutraSweet, because that also contains phenylalanine. So lots of nutritional counseling with that. For type 1 diabetes, remember that's where we're not producing insulin, and we present with the classic 3 Ps. Remember, type 1 is typically in our pediatric population. Type 2 is our poor diet and exercise. So we typically see it in adults. And then the increasing rate of obesity has also increased the amount of diabetes that we see. Home stretch, guys. Fractures, any traumatic injury to a bone. So remember the different types that we saw. We have a complete fracture where the bone is completely separated from itself. Incomplete is going to be your green stick fractures where only one side is broken, the other side is still attached. And then open fractures where we've got a wound associated with them. Any fracture that happens at a growth plate can cause that limb to not grow properly and can also be a source of infection.
Is green stick for a child? Sorry, is green stick the one for child abuse suspected? Or am I crazy?
A spiral fracture.
Spiral,
So
okay.
the spiral fracture is the one where somebody actually went and twisted their limb.
Okay, thank you.
So that's the one that you see. The green stick is where like only one side is broken, the other side still stays intact.
Okay, thanks.
On like a really young tree limb.
Okay.
They snap on one side, but not all the way through.
Yeah, I feel like green stick I learned for abuse, maybe for some other kind of class. I'm not sure, but okay, I get them confused. Thank you.
Yep. When we're assessing fractures, we want to make sure that we are assessing the 5 Ps so that we make sure we have appropriate blood flow, pain, pallor, pulselessness, paresthesias, paralysis. Any abnormalities in our neurovascular assessment have to be reported immediately so that we don't develop compartment syndrome, cut off the nerves and the blood supply. And then when we're doing traction, make sure we know how to position our bed correctly, what type of traction we're doing, what weights and pulleys we need, making sure we're doing meticulous skincare so that we don't end up with osteomyelitis. And our pin sites are major sources of infection. Making sure that we're not removing traction until we're told. And then again, making sure we're assessing our pain appropriately and using our IVs and oral medications instead of injections. For hip dysplasia, we have the positive Ortolani sign, where as you're moving the hips around, you can hear that clicking as the hip is popping out of joint. They also have unequal folds on their buttocks and thighs. So where that one hip is out, it causes your buttocks to be uneven. Same thing, we're gonna have limited range of motion on that side. And it usually ends up with unequal leg lengths. These kids are gonna be in a Pavlik harness and need physical therapy. We're gonna have difficulty with skincare and bathing while we're in that harness because we're in it all day long. Teaching parents how to diaper around it. And then follow-up care, they're gonna, as the child grows, that harness is gonna have to be adjusted pretty frequently. For scoliosis, this is what we assess for in grade school, making sure that our spine is properly aligned. We might see a hip or shoulder be elevated where that curve is. We're not going to be aligned. We're going to treat it with that Milwaukee brace for 23 hours a day, making sure that we put a t-shirt underneath so that we don't cause skin irritation, making sure that we're also not putting anything under that brace other than a t-shirt, no powders that are going to cake up in there. Probably don't want to use lotions either because you can cause, that's a great medium for infection. And then physical therapy to help them regain their musculature along with it to help support their spine. The brace doesn't correct the curvature, it just stops or slows the progression. If we have to move to rod placement to correct their scoliosis, it's really important that we log roll them because we don't want to be manipulating that spine. So we're going to use 2 or more people, and we're going to use that draw sheet to turn the entire body at once. And then we can use pillows to help support. For juvenile rheumatoid arthritis, we've got that inflammation in our joints, and we can have a systemic presentation when it affects multiple joints. We're really working on exercises, splinting, and promoting activity. So we can give NSAIDs to help with the swelling, also anti-rheumatic drugs. Corticosteroids also can help with their movement, but we also have to watch for side effects of the medications that we're giving. So if we're giving cytotoxic drugs, we can cause vision issues. So they will have periodic eye exams as well to make sure that we're not causing damage to the iris. That is it. We made it. Okay. Does anybody have questions on anything that we covered? I know that was super fast. Okay.
I do. For the Williams tumor,
The
when
Wilms, yeah.
I was doing my NCLEX,
Mhm.
and the answer for one of them, you said don't palpate the stomach because you don't want to spread the cancer cells.
Yep.
One of the answers was palpate the abdomen.
And it's wrong, I know. I did it too.
Yeah, no.
I don't know. Yeah, something. It was weird.
Yeah, definitely don't. We're all human. We can make errors in textbooks, but don't palpate the abdomen.
Okay. Because I'm like, it's on Saunders.
Yeah, no, that's definitely wrong.
No.
Definitely wrong. Don't do it.
Okay.
Your doctor will yell at you.
Okay.
Yeah, because
Thank
you're
you.
always supposed to oscillatate first.
Well, like I know this stuff, but like on like when you're doing your NCLEX question, it says for the Williams tumor to palpate. So I was like, wait a minute.
No.
No, because you can rupture it.
Yeah. Yep.
You don't want to palpate a tumor. Okay.
So we'll see how far we get through this, guys. There's 83 questions, so there's a lot of opportunities for practice here. Your HESI book also has practice questions that you can do if you're one that does better with just repetition and practice. Just exposing yourself to more questions. So that's another great way to study besides reading your PowerPoints in your HESI review book. Okay. I will drop the pin in the chat for anybody that wants to join us afterwards. And we will go ahead and start. If we have a 1-year-old with pneumonia that we put in a mist tent with oxygen, we want to keep that airway nice and patent. So the only way that we can do that with these list of interventions is that bulb syringe at the bedside. So remember, any respiratory disorder, your patent airway is your #1 priority. So bulb syringe at the bedside.
I love questions where nothing is wrong. And
Right.
it's always fun.
We didn't talk about mist tents in the PowerPoint. If you have a kid in a mist tent, one of the things that you have to watch for is making sure that you keep the sides tucked in so that we're not letting that humidity escape. And also watching their temperature. So with all that humidity floating around, those water droplets fall down on the child and can cause hypothermia pretty quickly. So make sure that you're watching their temperature, keeping them nice and warm. You might have to add extra blankets outside of the tent. Obviously, don't put them in the tent because they're just going to be saturated as well. So that knee chest position with our TET spells is to increase the blood flow to the lungs. So we're using our abdominal pressure to force more blood back to the lungs so that we can circulate more oxygen. When we have tetralogy and all of a sudden we're cyanotic, our stats drop, that's that TET spell. So the very first thing we do is that knee chest position. Strep throat is our cause of rheumatic fever. Our signs and symptoms are all of them. So the heart valve damage, remember, if we go untreated, we can cause mitral valve damage. We can have swelling in our joints. Chorea are those involuntary, purposeless movements. And then we have those subcutaneous nodules as well. So when we have heart damage associated with rheumatic fever, then we can see increases in our erythromycin sedimentation rate. We can see our heart rhythm changes, and then elevations in our C-reactive protein, which is a sign of inflammation. Our VSD, so our hole in the wall between the lower two chambers of our heart, can cause left to right shunting, which causes increased pulmonary blood flow, also increases the pulmonary artery pressure, and that causes that pulmonary hypertension. So if we've got increased pressure in our artery, as well as all this blood flowing at it, we're going to have pulmonary hypertension. Well, hypothyroidism, not enough, is going to be all those things that slow you down. So we're going to have weight gain, low heart rate, constipation because we have low peristalsis through our GI system, and then also cold intolerance. So our body's not going to be able to produce a lot of heat, so we're not going to tolerate cold temperatures very well. Parallel play goes back to the very beginning of our term, where we're playing alongside children, but not with them. Very common in our toddlers. We see this in our 2 to 3 year olds that are really centered in that egocentric thinking, where the world revolves around them. So acne is a local infection, meaning it's confined to that pustule, and it is caused by bacteria. So doxycycline is our double hitter. It can treat acne, and it also is good for sinus infections. Treatment for hip dysplasia is that Pavlik harness. We're looking for those signs and symptoms of hip dysplasia. We're going to have that positive Ortolani maneuver where we hear that hip click as we're moving the hips around. One leg is going to be shorter than the other, and then we're going to see those asymmetrical folds in their buttocks. For myelomeningocele, we want to assess our neurologic function, see how much it's impacted by that defect. And we also want to keep an eye on our urinary function. Remember, our nerve endings aren't completely firing, so the child's ability to empty their bladder might be affected. Remember, no latex with these guys. So with Milos, we've got our spinal cord that is outside of our body in that sac. So we want to make sure that we are using strict asepsis, making sure that we are protecting that sac, keeping it free of infection because it can go directly into our spinal cord. So you guys got it. Our number one priority is protecting this sac right here that's containing our spinal cord. So these babies are actually going to be prone or side lying until we do surgery to correct that and until that incision completely heals after surgery. Good job, guys. For epistaxis, that's our nosebleeds. We want to make sure that we lean forward and pinch the soft portion of our nose. If we have nosebleeds, we don't want to be on aspirin that affects our platelets' ability to function, which would decrease our ability to clot. With epispadias and hypospadias, we hold off on the circumcision in case we need that foreskin for skin grafting during surgery. We want to do that corrective surgery at 6 to 12 months before we start potty training and before that fear of castration starts to set in. Folic acid helps produce those new red blood cells so that we can dilute those crescent-shaped cells. So this is one of those examples that you have to read the entire question, because yes, folic acid prevents neural tube defects, but we're talking about sickle cell disease. So again, essential to red blood cell production and fighting anemia. Diaper weights have that 1-to-1 ratio. So 1 gram of diaper weight is the same as 1 milliliter of output. Pyloric stenosis signs and symptoms: projectile vomiting, poor weight gain, always being hungry. Current jelly stools are intussusception. This is just the other name for pyloric stenosis, and the main symptom is that projectile vomiting. Yes, we also have a palpable mass, but we have multiple disorders that have masses. So autonomic dysreflexia is where our blood pressure suddenly spikes when we have a spinal cord injury. So one of the things that can cause that is urinary retention. So if we have a full bladder, our body doesn't know what to do with it, so it just shoots our blood pressure up. The common presentation for this, like I said, with the spinal cord injury is you have a headache, high blood pressure, and a low heart rate. So we're going to do bowel and bladder training to make sure that we don't end up with a full bladder. So we're going to have this routine schedule where we empty our bowel and bladder. We can also dangle our feet at the edge of the bed to prevent any pressure points that might be causing pain, making this autonomic dysreflexia fire, and then obviously treating our hypertension. Yep, we know Lyme disease is transmitted by infected ticks. We are going to be on doxycycline, a systemic antibiotic to treat that bloodstream infection from that tick. One of the side effects of doxycycline can be soreness of our muscles. Anytime we have an infection, we want to promote that well-balanced, healthy diet to help with nutrition and restoring that minerals and vitamins that we're missing. So fruits and veggies are going to be our best choice of a snack here.
See, I was thinking protein, even though chicken nuggets aren't the best. But
Protein is going to be for wound healing.
okay.
Yep. The two of you are correct. Propranolol is going to be a blood pressure medicine. It has nothing to do with our thyroid. So this is the medication we're going to use for hyperthyroidism. So propylthiouracil, or PTU, decreases our production of thyroid hormone. So if we have too much, we can give this to stop it and bring our levels down. All of these are going to be signs of UTI. These are some of those more vague symptoms that we talk about. Our DTaP schedule is 2, 4, 6 months, 15 to 18 months, and then 4 to 6 years. With hip dysplasia, we've got one leg that's longer than the other, one leg shorter. It's going to be our telltale sign. We've got unequal skin folds, not necessarily more skin folds. We need all of these immunizations in order to be able to go to school. Remember, our Pavlik harness has to be on 23 hours a day, just like our Milwaukee brace. So we're going to be in that Pavlik harness as much as humanly possible. So the best intervention is going to be sponge baths so that we're limiting our time outside of our harness. Also knowing that we have to keep that skin nice and clean where it's underneath the harness. So we might need some intermittent sponge baths, even outside of our normal bathing schedule. So with our harness, anytime we've got our skin underneath the pressure of something, we have to watch for skin breakdown. Just because we're in a harness doesn't mean we're going to have delayed development or we can't hold them. And we're gonna try and diaper under the harness so that we aren't exposing the skin to our bodily fluids. For both head lice and scabies, we want to get rid of all of those mites. So we're going to make sure any soft items like clothing, linens, bath articles, we clean them in hot water, run them through the dryer on high heat. Anything that we can't run through the washer, then we're going to make sure that we tie it off in a garbage bag for a week. Good job, guys. When we have head lice, we know our education was effective if we're washing linens in hot soapy water. I frequently check the scalps of children for reinfection is one of those ones that you have to read very carefully. We're not going to go around checking random children for infections. We're only going to do that scalp check when we know that we're at risk. And we're only going to check our own children. We're not going to check strangers' children. So with our infants, when we're looking at causes of respiratory distress, any airway obstruction can cause respiratory distress. So if we're suctioning, we're preventing that. We know that if we have their temperature too high, that we can cause tachypnea artificially. Also too low, we can cause them to slow everything down and they can be low heart rate, low respiratory rate. And then we're going to treat those oxygen saturations. Hypertonic saline is one of those things that's going to help loosen those secretions for kids with bronchiolitis so that they can get it out. Our leading cause of poisoning in our kids are medications and drugs. So whether they have access to something that they shouldn't be in, or if we're giving them an incorrect dose of something. This is one of those we got to watch for that except at the very end of the question. So we know we need to increase our fluid intake to prevent UTIs, not limit. Signs and symptoms of appendicitis, that rebound tenderness, abdominal guarding, and pain at McBurney's point. You guys are waiting on me. So some of those other signs and symptoms we see are that pain getting better when we flex our hip, and also nausea and vomiting. So the most important thing to remember with cystic fibrosis is we have those increased secretions, and those cause all the problems that cascade through the body systems. So our toddlers with cystic fibrosis, we see steatorrhea, which is where we've got that fat into our stool. So we end up with those bulky, frothy stools. All of these are going to be respiratory signs and symptoms of cystic fibrosis. So we're at increased risk for infection. We're always congested. We have a low tolerance. If you think about anytime you have a respiratory infection and you try and exercise, you just can't do it. You feel like crap when you do. We're going to be using all those extra muscles helping us to breathe. And then we're going to see those changes to our lung capacity. So all of these are also signs of esophageal atresia or tracheoesophageal fistula. Remember, we don't have anywhere for our secretions to go, so they're just going to come out our mouth if we can't clear them. We're also at high risk for aspiration and choking because we don't have those good connections. And then we're going to have respiratory distress when we're feeding because, again, we don't have the correct connections between our trachea and our esophagus. So we are going to go ahead and stop there for today. So it looks like Taylor is our winner today.